All right. Hello, everyone, and thank you all for joining us for Hospice News Staffing Summit. I'm Holly Vossel, reporter with Hospice News. I'll be moderating this session entitled Bandwidth, Not Burnout, Insights on Enablement, Leverage, and Better Outcomes for Staffing and Patient Experience Results. Before we begin today, we'd like to thank our thought leadership sponsors, Access and Teletriage, Element 5, and CareXM, we have joining us today. And a great thanks to our awareness sponsor, Net Health, as well. We welcome questions at any time from our audience, which you can submit via the Q&A function. And if you missed any of our sessions this week, recordings will be posted at the conclusion of the summit and available for 30 days. Next slide. Oh, we're here. Okay, good. In this session, we will gather insights from our speakers into solving the root causes of staffing challenges and how hospice and home health providers can empower their care teams with work-life balance tools that deliver improved quality of care for both clinicians and their patients. We'll hear, next slide. We'll hear from Bristol Hospice, Goshen Health, Providence Home and Community Care, along with CareXM. And with us today, we have Jeanette Dove. She's Executive Vice President and Chief Quality Officer for Bristol Hospice. We also have Rebecca Alexander Leroy, who's Director of Home Care and Hospice at Goshen Health, and Kelly Carner, who's Executive Director of IS at Providence Home and Community Care, as well as Kevin Childs, who's co-founder and practice leader at CareXM. And actually, Kevin's going to be leading us through our chat today. So I'll now pass things along over to him. We'll kick us off from here. Go ahead, Kevin.
Super. Thank you very much. Appreciate it.
Sure.
Would like to thank Kelly and Jeanette and Rebecca for joining us in this discussion today. Just a very brief background on CareXM. We're a software with a service company. We support about 5,500 providers or locations across the country. We support all 50 states, and we facilitate about 8 million patient interactions on an annualized basis. Really, our mission as an organization is to help our provider partners in delivering better care outcomes for their patients. Today's discussion is really going to be built around some principles that we've really adopted. In fact, the whole healthcare industry is adopted from the Institute for Health Improvement, IHI, and the quadruple aim. It's really an element of all of us finding balance in elevating clinician experience with the patient experience to get better outcomes for those patients, while at the same time finding optimization in the dollars that we spend or the costs in delivering such. As we all live by the CAP surveys, as they're mandated, there are mandated elements, but on a day-to-day basis, we as professionals strive to deliver great moments for every interaction of the patients that may come into our world or that we may interface with. And one of the primary elements in delivering great care and great moments is to ensure that you handle it within a very short period of time. So much of what we do centers around minutes and around moments. One of the most expensive aspects of caring for patients is addressing unscheduled patient interactions. In this particular slide, the gray line represents phone calls that a patient may initiate back to the provider, home health or hospice provider. And the orange line represents the typical non-forecasted staffing component, meaning I know I'm going to get calls throughout the day and I'm going to staff accordingly. But unfortunately, we find that the staff is either overworked or underworked based upon those call volumes throughout the course of time. And what most organizations strive to do is to align their resources directly with that unscheduled interaction that may come in. Those unscheduled interactions may come in throughout the course of the day or evening or weekends. And that's the struggle that we have as providers in balancing that. Really, what we want to strive for is not to be overstaffed or there's a surplus or really inefficiency in our investment dollars for staffing, or we're understaffed and there's a deficit specific to the patient experience. And what you really strive for is that equilibrium point, aligning those interactions and needs with the appropriate resource at the right time. So to really talk about that, we're gonna talk about the baby bear principle, seeking the just right in our staffing. Too hot, too cold, or just right. A lot of organizations strive to do things internally, and that is really what we all want, is to deliver personalized care to that patient, whether they call it 2 o'clock in the afternoon or 2 o'clock in the morning. And a lot of times organizations find that they think it ends up becoming too expensive to do it internally. So they try to figure out why some of their they may be challenged with that. And when you look at the volume of interactions, the rate at which individuals come and interface with you, and you cross-reference that with the tools that may be available to drive better outcomes, we find across the board that if you're living under a 20,000 census, give or take, you're gonna be supporting that census with anywhere from 1 to 9 individuals that would come into traditionally a triage type organization. But unfortunately, if you have less than 20,000 census, you're going to find that workforce, because of the peaks and valleys of calls throughout the course of time, they may not be fully utilized, and they're going to be living at a much lower productivity rate, which means you end up having a much higher labor rate or cost of interaction. Now, that's not uncommon. In fact, most organizations across the United States, in and outside of healthcare, if you have less than 250 individuals in a triage or customer service environment, you're going to find that it's difficult to function in what's considered the upper right-hand quadrant, where, in fact, only 10% of companies today in the United States live in the upper right-hand quadrant, delivering high quality at a really low or efficient cost. Being in the upper right-hand quadrant means that you can strive for a first call resolution, a really fast speed of answer. You can predict your patient or customer satisfaction, and you measure your talk time and the efficiency that your individual has as they engage with their patients or customers. And then finally, when you're doing it right, you can really bring down the turnover in the staffing arena. In the home health hospice category, because you're at the very, very low end of the spectrum, most of the time there's deficiencies in the people, process, or technology arena. So a lot of companies say, well, if I can't do it on my own, maybe I'm going to swing the pendulum and go all the way and outsource the interactions to a third party, a triage or answering service, where they step in and say, look, I'll take care of all the problems that you have. I'll hire the people, I'll train them. And I promise that I can deliver the right kind of quality that you would expect and hope to deliver yourself. But in the old baby bear scenario, there's too hot and there's too cold. And when you end up sending all your interactions to a third party, it becomes very cold and it becomes very costly, because they do not have a direct relationship with those patients. Now, there's evidence in the market space outside of healthcare where some of the largest brands have attempted to send their customer interactions to a third party, where that third party says, I can interface with your customers as good or better than you. But at the end of the day, a third party can never do it as well as the case manager themselves. And unfortunately, a lot of times, if you do it 100% inside or 100% external, you tend to find yourself painted into a corner where you end up losing flexibility, control, as well as visibility of the outcomes with the patient until it's frankly too late. A lot of times you find out at the end of the day, months later, that you failed a patient at the wrong time. So the just right that we have found as we've built it collectively with our partners is that there are answers for hospice specifically to deliver the right kind of care with the right kind of cost, where you can outsource components of the people when you need it, process development improvement initiatives that can be delivered to frontline staff, as well as acquiring new technologies communication technologies that in many cases emulate the nurse call-like technology that these patients have adopted while they were in the hospital, while at the same time retaining control over the engagement strategy, the full clinical leadership, and the patient experience. And that's what we find is a just right, where there's a balanced balanced relationship between the patient, the clinician, and those that you may have back you up when you're not available. There's an XM customer experience scenario where when you give a patient a telephone number during the intake process and say, when you need to speak to your nurse, call this number. And inevitably many times when the patient calls a nurse, they hear, they go to an answering service, and they hear that we're going to page the nurse or we're going to route the call back to a triage group. And what we do as an organization is recommend that companies deploy technologies that will allow you flexibility in the routing, the recording, and the reporting of all interactions that would be interfacing with your EMR directly, so that when the patient calls in, the systems have the ability of routing calls directly to case managers or on-call staff, where then if they're available, calls go that direction. If they're unavailable, it may go back to a triage team. If the triage team is not able to handle the call within an appropriate service level environment, it could go back to nurses who could then coordinate care on the ground with the local case management team, or routing it out to a patient advocate environment. In many cases, what we're finding today, home health organizations specifically, they're looking at remote patient monitoring tools that allow them to proactively look at the patient to see how they're doing. There's many RPM type solutions out there that we would recommend that you would seek integrations with. One such organization would be HRS. But once you have the ability of bringing a patient experience into this type of a flow, there's significant benefits and balance for the nurse as well as the patient. So what we're going to do today is we're going to spend some time hearing the journeys that these three different organizations have gone down as they have deployed different innovations, typically technological innovations in their customer and patient engagement strategies. So I'm going to pass the baton to Jeanette Dove. She's going to give you a snapshot about her background and give you some very valuable information specific to data-driven results that they have found within their group. Jeanette?
Thank you, Kevin. Next slide. I found that just about everybody recognizes this group of gentlemen, and they are one of my favorites. I'm dating myself a little bit, but if you're a fan of the Beatles, you may remember a song that they sang. There was a little help from my friends. And I found in my career as a hospice nurse that you can only deliver excellent hospice care when you get a little help from your friends. So this Beatles song and this picture has kind of become a personal mantra for me. But on the next slide, I want to share a little bit about my hospice history. As you can tell by my gray hair, I've been a hospice nurse for quite a while, since 1986. And back then, our communication avenues were limited. Information was scattered, and we worked extra hard to coordinate and collaborate care while driving around our cities to see our patients. And in dating myself, I want to tell you a little bit about something I used when I was a hospice field nurse. And I like to call it my communication trifecta. Yeah, there's a trusty Ford Tempo there that I drove around in. And I carried a beeper on my belt and searched diligently for that elusive payphone in those days. There was no electronic health record, no cell phone, and no texting. It was very manual and it was very basic. But I remember driving those streets of my city, looking for those payphones, dreaming about a time when I would have every piece of information at my fingertips to deliver that good, solid quality of hospice care that we're all dedicated to. And I've been fortunate in my career as it's evolved that I found a lot of friends along the way that have made my dreams and visions come true. And I've seen hospice bedside nursing evolve into a highly skilled, technology-rich, metric-driven approach to care. And part of this, back in 2016, I found a new group of friends that expanded my dream and my vision when Bristol Hospice partnered with CareXM. We added the CareXM team to our Bristol Hospice team, and our journey began together. We integrated the CareXM processes, their tools and resources, into our daily practice, and we challenged our nurses and our leadership to openly share and impact our patients' care through meaningful metrics. Kevin, can we take a look at my friend slide 1 here?
Betcha.
I like to go back to that little help from my friends. And like I said, in 2016, we paired with our group, and that began to come true. And next slide. We began pairing data with intuition. And as time has gone on, we've all seen the heightened need for attracting and retaining nursing staff. And we've been challenged by our own creativity that has forced us to look at how we're doing things and how can we better deliver hospice care. We all begin pairing our need for innovation and our approach to care to delivery regarding staffing models together with our partners. Excuse me. Bristol began a census growth pattern, and due to our census growth, along with these staffing challenges, we began to experience an increase in our non-scheduled after-hour visits. And Kevin, if you'll jump to the next slide. Excuse me. This increase was resulting in added nurse pressure, and it impacted our nurse retention statistics. And with this in mind, we began a performance improvement project. Sorry. You can see with this graph, as we do with our performance improvement projects, we started aggressively digging into detailed data that was available to us through the CareXM portal. We studied the data and we determined we had that age-old supply and demand problem. Either we had too many nurses and not enough calls, or too many calls and not enough nurses. We definitely did not have a balance, and we had kind of lost our workforce equilibrium. So this is one of those times we needed a little help from our friends. Let's talk a little bit about this slide and our unscheduled patient intervention visits. As we reviewed this data, we developed a premise. We believe that reducing the patient's need for a non-scheduled visit would result in better patient and better nurse satisfaction. As we collaborated with our CareXM friends and analyzed this after-hours data, the pattern emerged and meaningful metrics were born. We were off and running. From this data, we began to understand what our challenges was. And we asked ourselves 5 pointed questions. Now there's a few questions in each one of these questions, but bear with me and we'll take a look and see what we did. Our pointed question number 1 said, based upon the data we're looking at, did we understand what our patient required after hours for a visit? On the graph, when did our patient call us? And why did our patient call us? And you can see from this graph, we were able to look at the exact times our patients were calling in and the exact times that our patients' calls kind of were at a lull. We also were able to look at the information and see, did the right nurse get the right call at the right time? Were the calls going to the designated RN case manager, to an assigned on-call nurse when they first came into the hospice? Did we make the patient comfortable when their calls first came in to who they wanted to talk to? Did we get to the patient's root cause of their concern when they called in? And was this done quickly? Question number 3, the group that we were asking, were we delivering an all-around proactive case management approach to care planning? Was our communication with our patients and families and the training we were giving them aligned with our IDT care plans? Were we taking advantage of tuck-in calls, symptom management calls? Were we doing preventative calls for visits? Were we pivoting our after-hour nurses to where the patient's needs were most acute? Question group 4, did we include direct care nurses in these staffing decisions? Who understands what's going on with their patients out there and what the families and patients' needs are better than the nurses delivering the care? So are we including them in this data and in these solutions? In question group 5, did we identify staff education needs? And did we train? Kevin, can we pivot to the next slide?
Yes, ma'am.
Thank you. With a little help from our CareXM friends and this 5-point question approach, we begin to learn more about what our patients and families needed and what our staff needed. We begin to understand that 24/7 proactive approach to hospice care was imperative. And with our CareXM partners, we learned we could dial up or we could dial down our staffing as needed and focus our staff where they were needed. We could request extra support during our peak hours and when we had emergency situations from our CareXM staff. So you see on our slide number 3, our friend number 3 here, the technology from CareXM enabled us to flex as we grew. And this is just a little snapshot from our enterprise level. There's lots of lines and bars on this graph, but this graph is important because it summarizes the data and how it relates to our growth and our unscheduled patient interactions. The solid black line is showing Bristol's growth curve. So you can see we spiked up and we were growing rather aggressively. And the blue line is showing during that time frame, using those 5-point question groups, we were able to reduce our unscheduled interactions and focus our staff on where the patient and family really needed us and when they really needed us. With the collaborative efforts with our CareXM partner, Bristol reduced our unscheduled interactions from 3.2 visits to 1 point. I'm sorry. Sorry, during the DREMA part, from 3.2 to 1.4 visits per patient per month during our after-hour period. That's a 50% decrease. And the caveat to this is all the while we were doing this and decreasing these after-hours visits, we maintained patient and staff satisfaction. So who wants a better answer than that? The data drove us to drive the questions, and the questions drove us to the outcomes. Remember our supply and demand problem? The next slide demonstrates how we address the individual locations needs. Based upon the location data, because Bristol is a large organization, so the previous slide was our enterprise data, but this slide reflects how we drill down to the location data. This data is from our CareXM portal, and we were able to individualize our location staffing models based upon the location's needs. As you look at this, it's our quarter by quarter data, and you can look at line 5 of our first call resolution numbers. You'll see in Q1, 47% of the time the RN took the first incoming call. Our Bristol RN took that call. But we wanted to do better than that. We knew we could do better than that. We were staffed. We knew that our nurses knew they had the information our patients and families needed. So we trained. And with that training and with our interventions, you can see in Q2 and Q3, we moved that number to 73% of the time. Our nurses were taking first call resolution. Our patient satisfaction improved and our nurse satisfaction improved. Our nurses knew what were going on with their patients. They wanted to talk to their patients, and our patients wanted to talk to them. These models met the needs of our patients and families, and it contributed to the well-being of our nurses. So all of the data that we can use from CareXM is valuable. It's valuable not only to the hospice, but it's invaluable to the patients and families. And with our CareXM partners, we had the dream. All we needed was a little help from our friends. And that's where Bristol went with this. Kevin, I'm back to you.
All right, thank you, Jeanette. I'll have to tell the audience that in the beginning, my partner and about 3-4 different nurses came together and said, we want to solve the problem for end of life care. And Jeanette and her team, they were much smaller back then, but we really sat down and took a lot of their wisdom in helping us create these models that would enable this and enable empowerment of the nurses as they engage with patients. So thank you, Jeanette. I appreciate that.
You're welcome. Thank you.
Rebecca, we'll pivot to you. What a great story you have.
Well, thank you. I'm excited to be talking to this group today, and quite honestly, I'm excited to be talking about anything other than COVID. So I thank you for that opportunity. Sometimes it's hard to think back to what we were talking about and what things plagued us back before a public health emergency. But when I think back in 2018, I took a hospice and home care leadership position for a small magnet hospital in Goshen, Indiana. Not sure if how many of the people on the screen know where that is, but we sometimes say it's pretty close to Notre Dame, where I did my graduate work. And we had some pretty big challenges back in 2018, and we weren't even aware of the fact that COVID was on the radar. And so one of the things we're faced with is some really ineffective staffing patterns. At this point in our organization, the majority of our colleagues were either part-time or PRN. And they had the expectation that they would still do nightly call rotation and they would still do weekend and holidays. And this staffing pattern really evolved because of the burnout that our full-time case managers had faced over time. The other thing we found ourselves in is declining patient satisfaction scores. And that really was a shock to us at Goshen because we had prided ourselves for over a decade in always being up in the 95th percentile. And for the first time, we started to see some of those numbers slip. At the same time, we started to see complaints really rising. So we had lots of patients calling in saying they weren't happy or bringing to our attention or to the leadership's attention things that had happened in the field that they weren't happy about. The primary of the complaints are really focused around the fact that I never know who's coming to my house. Someone different comes every single time and I have to tell myself again. As well as I never know when my next visit's happening and I don't know where my supplies are. And so we had to really begin to address that as well as our response times. We live in a very kind of rural area. And so we had one on-call nurse and she would, one for home care, one for hospice, and they would answer all the calls. Well, sometimes they'd be in a visit, a death visit. And so we prided ourselves at this point in being able to respond to an incoming call within 30 minutes, knowing that sometimes drive times could be up to 60 minutes to get to the next location. This was all really affected just poor case management. And these were the symptoms of what was happening. We also started to see the signs of burnout and compassion fatigue. And if I have you each think about when you start to see this in your organization, you're sitting around the table, maybe it's an IDT, and you see a lot of bickering going on. There's a lot of complaining behind the scenes. We started to have a lot of emotional outbursts sometimes in our IDTs. We saw a rise of increased sick time and our turnover was becoming a problem. At Goshen, we had prided ourselves for over 2 decades with great turnover rates, and most of the time our nursing colleagues were below 10% of turnover. And for the first time, we hit about 30% in our turnover of nursing colleagues. And then I feel like the final boom came. At the end of the year, we got our colleague engagement survey results from Press Ganey. We typically survey every 2 to 3 years with them just to find out our level of engagement of our clinical and non-clinical teams, how well they feel connected to the mission, to the vision, and how resilient they are. And little do we know, this term resiliency would be on our radar for the focus point from then on. So our results came in, and normally Goshen does very well. I would say we tend to do around in the 90s, but all of a sudden our resiliency scores dropped. And particularly for home care and hospice, this was our #1 indicator that we were really heading toward burnout. So we had to create a response plan. So what did we do? The first thing we did is listen to our colleagues. We started having some focus groups and bringing folks together to talk about what were they longing for in terms of the work. And the #1 thing that we heard was the call time. The call is just unbearable. The perception of call, the fear that I am going to work these long hours, I'm going to get hurt out there because I need more sleep, and that inability to really have work-life balance and disconnect from work were prevailing themes. Right about that time, I happened to go to a conference and met a CareXM representative. I think the conversation went a little something like this: I really need your help. I started explaining all the challenges we were having with call, nurses really frustrated with the amount of calls they were getting, and really felt like if we don't turn the ship around, we're going to be in a lot of trouble coming here soon. And so the first thing we did is implement CareXM, and I think if our implement strategists had to speak on it, we may have had the longest rollout in history. I mean, the nurses initially were not in love with it. And they were concerned that we'd lose our small town feel, that connection that we have with patients would all be lost when people outside of our community started speaking to our family and friends. Because in a small community, the people who are on hospice and home care are our family and friends. And so we took a lot of time to really engage our nursing colleagues in how this would look. When would the calls come? What kind of calls would come to the nurse versus the triage? They weren't overly excited in the beginning, but they eventually decided to go with it. The other things we implemented, we restructured our whole staffing pattern. We actually converted from all of our part-time clinicians to salaried full-time case managers with productivity expectations. We were really suffering from a lot of overtime, maybe over $300,000 a year in overtime for such a small team. And with the savings that we had in this restructure, we were able to actually hire permanent staff that covered the evenings, and then permanent staff who covered the call on the weekends. So it really freed up the case manager to focus on case management. So what happened? This is the exciting part, but I love this slide in particular here, because if we look at $270,000 we estimate for RN turnover, we were getting hit twofold. We had about this much in overtime for our hospice program and increasing turnover exponentially. So in the first year of implementing CareXM and our restructure, some really exciting things started happening. The first thing that happened is in 2019, our overtime dropped by 70%. Now, if you want to get your bosses happy and get the VPs smiling, you start talking about reducing overtime by 70%. The other thing that we did, and as Jeanette talked about so eloquently, we started to reduce the calls that came after hours, because quite honestly, the better we got at case management during the day, the less calls came in the evening. And we discovered we weren't near as good at case management as we initially thought we had been when we started to look at the type of calls that were coming through about when's my next visit, I ran out of my script, those kinds of questions. We also saw a drastic reduction in our call times. Families were delighted that they could talk to somebody immediately And they never even recognized that this wasn't somebody that they hadn't seen at the grocery store or at the local T-ball game. And we started to see our customer complaints go down. But I think the biggest win here was our change in perception. The nurses started to feel like I can actually get away from my work. It is not imperative that I call my patients on the weekend, even when I'm off, because I'm so worried that the care won't be consistent, or there'll be long delays when someone reaches out to them when they call after hours. And so the first sign of this was we started to see increased requests for time off, right? I feel good enough about the work that's going on here that I can be away from the work and step away, and I'm ensured that my patients will be well cared for. The most exciting part, though, are the unexpected consequences. These are things in the best planning we never really saw coming, but we're really delighted about it. The first thing that happened is this improvement in our after hours documentation. And I'll tell you how this happened. So we started looking at the notes that the triage nurses from CareXM wrote, and they were good, right? They were clear, they were concise, and they were actionable. Our nurses started patterning their documentation on what they saw the CareXM nurses do. I didn't see this coming, but when we surveyed next time, one of the last things we heard from the surveyors, wow, your documentation has really come a long way. We also started hearing from nurses that they really enjoyed talking to the triage nurses. I remember talking to one of our case managers in a follow-up call, just how's it going with this handoff? And she said, you know, we work in silos as a hospice nurse or a home care nurse. We're out there by ourselves. But it is really helpful to me when the triage nurse calls to hand off the call. She kind of talks me through all the things she did before she called me. I started vetting out, hey, you know what I think I'm going to do next is X, Y, and Z, and then got this confirmation from like-minded thinking colleagues who were in the moment. And so our nurses started seeing this handoff as a real opportunity to develop some other tools in their toolbox in terms of working with patients in the community. And the best news of all, our now 2022 colleague engagement results are in. And what we saw is that overall healthcare has taken a decline. We're not surprised by this. We've also all come through a pandemic. But what we saw is that home care and hospice had the greatest gains in resiliency scores of any department in our organization. Resiliency being that ability to handle very difficult crises and still stay engaged in the work and know when you need to step away and come back to the work. Just recently, and I'll end with this, we had a town hall, and we had a lot of these in the beginning of the pandemic and then started to wane off. But we recently had a town hall, and I wanted to talk to the colleagues specifically about what the last 2 years have felt like and give some homage to where they had been and the experience they had had. And so I put the question out there, if you could come up with a word or two to describe the last few years, what would it be? Now I planted a few people in the crowd just to make sure that someone had something to say. And here's how the conversation went. The social worker chimed in. And she said, if I had to describe the last 2 years, I'd say my word would be survival. Survival. And then that kind of resonated with the group until one of our case managers chimed in. This is important because this case manager in 2018 was part-time, disgruntled, and we had had a few conversations that we like to call the stay conversation. Should you stay or should you go? Perhaps this isn't the environment where you can live out your personal and professional mission any longer. And so we had had a conversation like that in 2018. This colleague now is a full-time case manager and actually leads and represents our department in our shared governance structure in the greater hospital. And she questioned the group, like, survival? Is that how we really think? I think we did better than survive. Not only did we survive, but we have thrived. And now with our colleague satisfaction numbers coming in, we know that the direction we took to really get our staffing pattern in check and deal with our on-call crisis for a small team that is sometimes really burdened by this. We took the right steps. And so it is, I think, a really unintended consequence that we started talking about resiliency long before we ever hit the pandemic. And so we are happy to report that at Goshen, we've been doing a little more than surviving through a pandemic. We've actually done some thriving. And may I say, Jeanette, with a little help from our friends.
Rebecca, that was amazing. Thank you for that story. Thriving, surviving, and in the moment. Those are the memories here. In the moment, minutes and moments change outcomes with patients. Okay, we're going to pivot from a very talented administrator in Rebecca, and we're going to now go. So Jeanette was quality, Rebecca was administration. Now we're going to go to IT, and boy, some of us know how IT is. Those IT people, right, Kelly?
Absolutely. Thank you, Kevin. That's quite the introduction.
Well, nice thing is Kelly became IT by the route of becoming a nurse first. So
where I really want to wrap us up with is talking about how this technology affects patient care and how it affects our businesses. Just simply from even our own experiences with our loved ones or our own experiences of patients, it's very easy to get into that experience where you are calling and you get somebody who takes a note. And then the next person calls you back and you repeat what you said on the note. And then they say, okay, well, we're going to go talk to somebody else. And then you get another call and you repeat what was said on the note. And this is not only is this hard on patient satisfaction, but patient satisfaction equates with efficacy. And when we start talking about all of that note taking and all of that repeating yourself, what we're really talking about is wasted caregiver time. And not only is that a problem with caregiver satisfaction, it's a problem with patient satisfaction. And what I have really seen is that we are just on this precipice of saying we need technology that keeps us from wasting our time. We've been fighting this world where technology just keeps growing and growing, and we put more and more energy into it. And we're finally at that place where we're saying, hey, let's implement a technology that helps us be more effective at its absolute core. And that's what we're seeing here, is that this is one of those technologies that takes something as simple as caller ID, coupled with that, what we are already charting on our care team in our EMR, and using that to get the call to the right person on the first call. So not only are our caregivers not answering calls our field caregivers, not answering calls for people who aren't their own patient, but they're answering their own patients' calls, and they're much quicker and faster at being able to deal with that than if you send it to somebody else. And it also maintains that relationship with them. And we see that as incredibly important, not only patient satisfaction, caregiver satisfaction, but then also in that time and not wasting that energy in there. This is really just the tip of the iceberg on where we get into when we start saying, okay, now we've enabled this in the world where we are actually having these calls go routing during the day to the case manager, to the correct RN, and then the patient gets that experience, and then we get all the metrics out of it. So we've got less wasted time on the caregiver side, but then we're also less wasted decision-making on our business side. And those two are big pieces that I just see technology really helping to come together. I started my journey. I was not with Providence when Home and Community started its journey with CareXM. So I came into a world, and I will save us all and go back to a world pre-COVID, where I watched a natural disaster. You want to go ahead and change the slide, Kevin? I think this is what all of our last 2 years have kind of felt like. But even before that, we had what was called Snowmageddon in the Seattle area, where Seattle, which usually doesn't get a ton of snow, got buried in feet of snow. For Alaska, that's not that big of a deal. For Seattle, things came to a grinding halt. And from the technology strategy side, I'm watching this, and we've got administrators driving people around. We've got front desk out who had a 4-wheel drive out delivering supplies. We've got every nurse that has a vehicle can get out there, out seeing whatever patient they can see. And I'm like, how in the world are we maintaining these patient calls? And this was when I realized the power of what a platform like CareXM brings, because it didn't just activate, even though we're a large company and we have resources, we're not set up to activate like this at a moment's notice in disasters. This has saved us as an organization so many times, not just Snowmageddon, where patients, of course, are always they're more patient because they're also snowed in too. So we understand this, but there's certain things you can't put off. And now over these last years, we've seen everything from snow to fires to floods to staffing crises, some of them caused by the COVID, where you end up with the staffing. But I mean, I worked in a clinic that like half of our staff went home sick with norovirus one day. These things happen outside of that. And then also into this world where we're looking at contingency planning and strikes and network downtime, and just really saying there are times where we as a business need help. And that's what this technology allows, is this seamless help where we know that we have nurses on the other side, that if it can't be us, please let it be them rather than an answering machine or a non-medical answering service, because at least then they can get things rolling and they can still seamlessly send messages or call when it's appropriate into what's needed. And there is so much power in that. As a large organization, theoretically, we could spin up something like this, but what working with another vendor allows for is that they've done the software, they've figured out the licenses, they've figured out the legal, and they figured out the phone app and the infrastructure that it takes to make this happen. And we didn't have to do that because that's not what we're good at. We're good at giving hands-on care. I'll wrap up our technology conversation with really talking about that idea of partnering in developing models of healthcare. We are at a huge time of innovation in our industry, and we all know it. So Jeanette, I loved where the pager and the cell phone and the payphone. We're like, I'm pretty sure we have nurses on our staff now who have never even used a payphone. But we are moving so fast in our industry. There are so many changes and there are so many options for technology that are out there today. And it's overwhelming. I mean, I know it's overwhelming for me in my position, and I do technology, right? This is really rough. And especially for our companies in this industry that's saying, what's really going to happen? How can I really get to here? And this is where I think that companies like CareXM that talk about partnering is so important. There are a lot of companies that are trying to break into healthcare or have a healthcare division where they're saying, here is my product, and my product is going to solve healthcare. Where what we really need as an industry are partners who are saying, what is your problem and how can I help you solve this? And this is something that I have seen consistently with vendors like CareXM that want to be a partner in creating this model of how do we give healthcare. And I know it sounds to say, oh, caller ID. Yeah, well, we could all have caller ID, but how we apply it is really in that ability to say, okay, how do I make this work? I have this problem. How do I operationalize this? What does this mean to me? And so really just that call to say, make sure when you're looking at your vendors that you've got somebody who wants to partner with you in that aspect. That's going to be huge as we move into our new technology and say, hey, let's really make this technology work for us.
Thanks, Kelly. Appreciate that. Kelly, in your world, how long have you been in the IT side of the house? You moved from an RN, the clinical side, to the IT side. How long has that been for you?
It's been roughly about 10 years. I was 20 years hands-on care, and then I've moved into the technology, informatics, strategy about 10 years ago.
So can you give the team just a snapshot as it relates to your role, how your role is breaks down the bits, the bytes, the blinking lights, the things that are scary with technology, and how you sort of are that translator for the clinician side of the house?
Yeah, I think this is a big problem in healthcare today is we've got a bunch of technology people who are saying, okay, here's how it works. And we have a whole bunch of operational people who are saying, okay, but this is what my operations needs. And this is how my operations work today. And really, in my position, my role is to say, okay, this is the technology that we have access to. This is the technology that's going to work for whatever reason, be it agreements or legal or price, or like we've all got boundaries that we work within to say, what are those boundaries? And then to really say, okay, this is the technology that we're going to use for this purpose, and this is how it's going to integrate with our workflows.
Mm-hmm. So let me pivot back to Jeanette. Jeanette, go back to your first three friends in the hospice space here. These were your friends here. You were a pioneer of sort of deploying advanced communication tools into your environment. You didn't have a Kelly at the time that was there to help you feel comfortable with that. What was it that, you've been around the block a few times, starting with the pager. What was it that gave you the confidence to sort of say, you know what, I'm gonna break the mold. I'm gonna do this?
Well, I think it was just that tenacity to know that there was something better, that there was something on the horizon. Healthcare was really beginning to change. Technology was coming into the play, more at the hospital level, but then taking it and helping others imagine what it could be in the hospice industry and the home care industry, because both of those industries were a little bit out there and not in the mainstream yet. So I think it was just being able to get somebody else excited about what it could look like. And one of the partners that I had in the early days, back when those three tools were my friends, was a person that was working part-time at a hospice in IT. Back then it was just setting up the computers, teaching us nurses how to use a little bit of the basic technology, that also had a great vision and educated me. So I think it was just that desire to take it into the hospice and the home care industry and have people that were listening.
Kelly, can you, thank you, Jeanette. Could you comment on any comment specific to, that you've got some rather large populations up there in Seattle, Oregon area of nurses. How have your nurses, Rebecca shared that there was a little bit of resistance on their end of sort of adopting, change the concept of change management there, but how has your organization been able to sort of integrate advanced tools into a workforce without fearing that the workforce is going to say, oh, I don't want to deal with change. I'm happy with my flip phone and the old way of doing it.
This is a really good question. And I think Jeanette just nailed it. It is really that ability to paint a picture. And this is what leadership does, right? We come out and we paint a vision so other people can see it. And then they say, yeah, we can make that happen, right? You have to have an end goal in mind. We see Providence's Home and Community is the largest nonprofit home care organization in the US. And we have we've got 7 major service lines and various levels of rollout of CareXM across the organization. And so what we see in our organizations, in our ministries, that we have the highest amount of adoption that are using the app. They log into it. They keep the EMR updated so their care teams are up to date. They're texting back and forth in the app with the triage nurses, and it's this seamless care team. It's really because their leader has been able to paint a vision for them and they've been able to see it.
Yeah. Thanks for fielding that question. Grace, Holly, any other questions you want to?
We just had one question from our audience that we wanted to get over, which is actually, I think, a good one for you, Kevin, just in our last few moments here. For a small hospice provider with a census that's below 100, let's say, is CareXM still a viable option, or is it cost prohibitive until a certain patient census is attained? How would you answer that question, Kevin?
The absolute smallest hospice is someone that has just received their licensure. So you're hiring your very first nurse and you don't have your first patient yet. Those organizations, the beautiful thing about our technologies and our people process technologies is completely variable. So if you're small, there's rather limited expenditures on your side. We flex up and we flex down. In fact, if you were to look at Jeanette's slide here that she had mentioned, this blue line, when this blue line was high, they didn't really need us. They were just leveraging the tools to do it themselves. As that line came down, we step in and we step out, and it's very affordable for a brand new hospice organization. I'd say the first 30 customers of ours back 8 years ago, they were all under 100 census.
Gotcha.
Now it's changed significantly.
Well, thanks for that insight, and thanks for each of our speakers sharing their thoughts and their experiences. We're coming up to the end of our time here, and I think that wraps up our topic pretty nicely. Thank you for our audience for joining us, and thank you to CareXM for sponsoring the session as well. We'd like to invite our audience to stay tuned for our last talk coming up next with Hospice News editor Jim Parker. He's going to sit down with Silverstone Hospice CEO Alfonso Montiel for a C-suite perspective. Thank you, everyone, and I hope you take care for the rest of your day.
Thank you.
Thank you.